Legg Calve Perthes disease. It is a disease of mainly the boys, that is from 4 to 8 years of age. In mostly the boys are mainly affected, although it can be females, but mainly it affects the boys. It's actually a pediatric condition which is more predominantly affecting the hip joint of the child, usually at the 8 years of age. If you see, this is an X-ray which is classically depicting Legg Calve Perthes disease. Usually these children come with a limp which is mostly painless, and then when you get their X-ray pelvis AP view, what you get is a deformed head. If you can appreciate it over here, although this child, if you appreciate in this X-ray, this probably striradial cartilage is closed. Therefore, this child is definitely above the age of 8 to 9 years of age. But you can very well appreciate considering what you see it on the left side, and if you see the right femoral head, you can clearly appreciate there is definite subluxation as well as deformity of involving the femoral head. Actually, it's a disorder of the problem is with the vascular supply which is reaching the femoral head. If you see from 0 to 4, just after the birth, usually the main supply to the femoral head is via two things. There is fovea capitis. This portion is mainly supplied by the artery to the ligamentum teres, and mainly it is actually coming from the lateral circumference femoral artery. By the time from 4 to 8 years, there is actually shift from predominantly supply from lateral circumference to the medial circumference femoral artery. And in adults, the predominant blood supply to the femoral head and the neck region is actually through medial circumference femoral artery. During this shift, the head is actually more susceptible, and if there are associated risk factors, for example, early walking or increased weight bearing and any traumatic history, this may be associated or may predispose a child, usually a young child, boy of 4, 5 years, 6 years of age, to this Legg Calve Perthes disease. Now, there are certain associated disorders which may be present in the patients of LCPD or Legg Calve Perthes disease. For example, the most commonly associated orders could be genitourinary malformations. This could be present at the time of birth, or they may develop like hypospadias, which may develop over time. And usually there's always genetic predisposition to the malformations in these areas, which eventually may mimic or which may also predispose a patient to having a problem with the femoral head as well. Then it could be associated with undescended testes. Cryptorchidism is also associated with the Legg Calve Perthes disease, and as I told you, hypospadias, cryptorchidism is association with LCPD. There could be associated inguinal hernia. The region is actually the hip and pelvis and inguinal region. And if there is associated malformations, these children may have genetic predisposition of developing the LCPD. And then this may be associated with Down syndrome. In children with Down syndrome, there are certain things which are more predominantly associated with. For example, these children have a high association with atlantoaxial rotary instability. Similarly, they have also association in the hip level. They have more increased chances of developing a LCPD or Legg Calve Perthes disease. And then certain coagulopathies, for example, protein C and S deficiencies, they may predispose and may be actually involved etiologically in the vascular insult which may occur towards the head. When this shift of the vascular supply is actually taking place, this will eventually lead to Legg Calve Perthes disease. There are certain risk factors which are associated with Legg Calve Perthes disease. For example, the first one, which is more commonly is associated with, it is usually in children who are born with a low birth weight. Therefore, when a child comes to you with a limp, you have to take the antenatal history to was this risk factor present or not. The next is smoking in mother. If the mother was smoking at the time of pregnancy, this can predispose her to many other causes, but one of it is actually the Legg Calve Perthes disease. Then short body length at birth. Usually, if the child is of low birth weight, there will be decreased crown lump length, and this may predispose the patient to this problem because usually the hip are at more flexion as compared to a normal baby. Then there may be associated family history. You have to inquire about whether this problem is present in siblings or not, and was this present in parents or not, or when the parents were, was this sort of a problem which really actually occurred when they were very young. Usually it's seen in the lower socioeconomic status, because you have to inquire about the occupation of the father, because usually in the lower socioeconomic status there are cramped spaces, and that's why the hip of these children are actually more predisposed to these problems, especially with nutritional deficiencies which may be running there along with that as well. And lastly, it's usually associated with attention deficit hyperactive disorder type 1. ADHD has been associated to be linked with LCPD, when usually although it's one of the rare causes, but it can be associated with Legg Calve Perthes disease. Now, pathophysiology. What actually happens in Legg Calve Perthes disease? If you see, the problem is actually, as I just told you, the brunt of the problem is the disruption of blood supply to the femoral head. Now, this could be lost due to when the switch is actually taking place. This may be associated with coagulopathies. There may be associated with trauma which has resulted in this sort of a problem. There could be other associated issues like protein CS deficiencies. Once that disruption occurs, then there are certain changes which occur in the head, from articular cartilage of the femoral head to the femoral epiphysis, physis, as well as metaphysis. And that actually, once the disruption occurs, this can affect articular cartilage in a way that it results in the necrosis of deep layer, because as you know, the articular cartilage is devoid of its own blood supply. It's actually receiving blood supply from the femoral head via and diffusion. The nutrients and oxygen is actually reaching the cartilage. But if there will be no blood supply, there will be no oxygen, nutrients, and eventually necrosis of the deep layer would occur. Then there may increase cartilage vascularization, hyperemia, and like a situation in which there's increased degeneration which may be present once the disruption occurs. And deformity may worsen if restoration of epiphyseal growth is asymmetrical. What would that lead to? Because there is increased load and stress rises at a certain level than other areas, therefore there will increase chance of degeneration of articular cartilage in certain areas as compared to the other. Now, it can affect articular cartilage as well as the epiphysis. When it affects the bony or femoral epiphysis, actually this results in extensive cell death. There is increased bone resorption. Once the bone becomes necrotic, this leads to resorption and fragmentation. And we'll be discussing the Waldenstrom staging later on this same lecture. And then this results in, once the fragmentation occurs, the collapse occurs, and this eventually leads to femoral head deformation. And deformation can eventually be permanent, or which may remodel actually to a normal head as well. Then what happens to the physis? As you know, the physis is also needs, because it's the most growing part of the bone, therefore it needs vascular supplies to make new cells, and it can actually elongate the bone. So therefore it may develop physeal damage and lead to growth arrest. If the growth arrest occurs, although the majority of growth is occurring at the distal femoral physis as well as the proximal tibial physis, but it can actually result in a 3 mm per year and if growth arrest suppose it occurs at 4 or 5 years of age, that means by the 10 years there may be as much as 3 centimeters of shortening, or 3 to 4 centimeters of shortening may occur, and that can be problematic later on. Then there are certain changes in the metaphysis as well that results in a radiolucent lesions below the physis, is because of increased sclerosis and bone necrosis over there, along with physeal damage, which may result in, is called as actually metaphyseal cyst formation takes place. And there is also called as rope sign, in which there are multiple metaphyseal cysts and blanch signs which may appear in the metaphysis. Now, clinical presentation. Now, what is important is that if you remember the case which has been just been discussed, there was actually a painful limb. Now, usually when a child of 4 to 5 years of age usually comes with a limp, and when you ask, okay, is there pain somewhere, and he points out to his or her hip, then the first thing which usually with this age group what should come to your mind should be the LCPD. Although usually it's a painless limp, but it can be a painful limp as well. And that is something which you need to remember, that it sometimes painful limp could be LCPD, or it could be mostly it's the painless limp, or and then maybe painful means there could be acute infection as well in form of septic arthritis, acute femoral arthritis as well. But if there is swelling at the hip joint with a painless limp, yes, you should think about LCPD, but you should also think about transient synovitis of the hip joint, which may also mimic some of the symptoms of LCPD as well as the septic arthritis. But once you will get the lab workup, usually for transient synovitis, the lab workup would be normal. And with LCPD, yes, there will be raised ESR, but may or may not be other C-reactive proteins, other markers may be negative. Usually, if the age is from usually 4 to 8, but that does not mean that it cannot present in a child after 10 years. Now, if a 10, 11 years, 12 years old child presents with a painless limb with raised ESR, then you must also keep clipped capital femoral epiphyses in your diagnosis as well, or in your differentials as well. But if a 12-year-old child comes with a limp, the first thing should be clipped capital femoral epiphysis as a SCFE. Because usually the age is 4 to 8, but rarely the patients with LCPD can present late as well, and as late as 20 or 25 years of age as well. Now, coming to the physical examination. Once the child comes to you with a history, there will be on the major symptom would be a painless limp, and there will be no antecedent history of trauma, as it was in our case as well. When we inquired about it, was there any trauma? There was no trauma. Was there any associated, did that child had a fall? John did not have a fall. There was no associated trauma. There was no associated. The only problem was that there was insidious onset of a limp, which was painful, with no associated fever as well. So if the fever is not there, there is no trauma there, then less likely is to be a septic arthritis, transient proximal femoral osteomyelitis. Yes, it could still be proximal synovitis of the hip joint, but usually when you get an MRI, and if the MRI comes out to be negative, then probably most likely the diagnosis is going towards the LCPD. Then there are certain things you have to look on physical exam. On physical exam, the first and foremost is hip pain. Usually, about 1/3 of the cases there is painful limp. Then on hip flexion or maybe contraction may be present if the child is having a chronic problem. In our case, it was history of just 1 day. But if the child has been limping for, let's say, 3 or 4 months or 6 months, then this may be associated with maybe some form of flexion or extension contracture at the hip joint. Then loss of epiphyseal height. This is usually important to understand that there is always called as vertical alignment of the physis. This becomes more vertical because if you see it over here, normally physis is like this, but it's becoming more and more vertical because of decreased joint space, because the physis is getting damaged and there's actually growth arrest is occurring. Once you get an X-ray, there may be associated proximal femoral deformity, which can be seen in the case of the head, or there would be some sort of other signs which we'll describe later on, such as Gage sign or Kapner sign. Then usually there is less likely to be associated with hip abductors, or hip musculature is normal most of the time. But for example, if there's a chronic history and child is not actually using hip muscles regularly, or is actually due to pain, the child is not moving his or her muscles a lot. Therefore, usually the contractures results, and this may eventually result in either the weakness of the abductors, or this may result in some form of contracture of the hip joint, which may not be the actual initial problem for which he is actually seeking medical attention. But over the period of time, due to chronicity of the problem, this has resulted that child has formed sort of a compensated mechanism, which may result in this sort of a situation. Then Trendelenburg gait may or may not be positive, but if there is associated gluteus medius and minimus deficiency, then abductors deficiency will eventually lead to tendon gait. And leg length discrepancy, that is actually very common, especially if there is a problem with the healed Legg Calve Perthes disease. The patient had acute symptoms, they were diagnosed, later on the physiotherapy was started, but eventually the physis damage resulted in growth arrest. And over the years of time, the patient may become painless, but eventually the limb length discrepancy will develop later on, which may eventually require redressal of the problem. Now coming to classification, there are different classifications which have been actually used for Legg Calve Perthes disease. Actually, the main problem was how to correlate this classification with the prognosis and sometimes how to manage the treatment. Later on, it was not actually, except herring, there was no real one classification was actually serving all the purpose. Therefore, to assess the severity of the Legg Calve Perthes disease, it was the lateral pillar or herring classification. But to assess overall the prognosis, there are different other classifications which are also found as well. Most commonly, it is the Catterall classification. Now, Catterall classification is a different group from group 1, 2, 3, and 4 as well. Initially, if you remember, if this is usually may involve only the epiphysis. As the blood supply is compromised, there will be actually necrosis of the epiphysis. If the epiphysis is anteriorly necrosed, this is usually type 1. This could be a central necrosis of the epiphysis. This is called as a Catterall grade 2. Then this may be associated with almost the complete head except small part. And if whole of the head has involved in collapse, this is actually this Catterall grade 4 type of a Legg Calve Perthes disease. But usually Catterall classification is important because the more the Catterall classification is, the more severe the problem is. So usually Catterall 1 and 2 are the mild problems, but they are more complicated or severe problems in Catterall 3 and 4. Now another classification is Salter and Thompson classification. Now actually it was also, it has to be made eventually redundant because the problem was that only 33% of the patients eventually develop fragmentation of the bone. That is, once the blood supply is compromised, there is increased sclerosis, and eventually there is subchondral collapse, and epiphyseal bone actually starts to collapse. Once this collapse is actually made by Salter and Thompson classification, or it actually made the fragmentation. It could be a mild one, it could be involving whole half of the epiphysis. Eventually, as the grade improves, there is increased physis involving eventually in the grade 4, it may involve whole of the epiphysis. And as the stage progresses, this actually means there is increased fragmentation and there is actually decreased degeneration of the hand and increased chances of growth arrest. But usually the Salter and Thompson classification is not actually followed because only the 1/3 of the patient actually develop fragmentation despite having the vascular injury. So we had to have some other formation of something else which we can actually diagnose exactly the prognosis of the disease. And for that came the herring classification, which was actually the lateral pillar classification. If you see, this is the normal head on the right side. It can be divided into 3 pillars. If you divide it like 2, this is the lateral most pillar, this is the middle pillar, and this is the medial most pillar. This is actually, the concept is that how much the lateral pillar has gone down. It could be type A, type B, type BC, which is the borderline, or type C, in which how much the loss the lateral pillar has actually suffered and how much it has actually gone down is what denotes the herring classification. That's why it's called as the lateral pillar classification. So type A is in which only small part has actually gone down and it has good prognosis. Type B, in which almost 50% has gone down compared to the other side. Type BC is borderline, sometimes you can say almost exactly 50% of the head is gone. Type C is in which more than 50% of the head is actually gone as compared to the opposite side. Now, as the herring progresses, the type B, C, and C have a bad prognosis, and usually A and B have a good prognosis. So that is how you divide the herring classification. Later on, what is important is that it actually also signifies how much the prognosis will be. If it's heading A, that means there is a good prognosis and you can go for conservative management. But if it's a heading C and the child ages more than 8 years, this means it's not gonna be having a very good prognosis, and then that means you need to intervene early and do something about it surgically. Other classification was also by Stulberg grading. Now, Stulberg grading, remember, is not a classification for acute stage. Once the head became reossified and eventually remodeled, sometimes the remodeling was absolutely complete, but in other cases, the remodeling was not complete, resulting in some form of a deformity. This Stulberg classification is for the deformity with which the head or the femoral head may present. It could be round head with a normal hip. This is a normal head which completely remodels, which is called as grade 1. Or it could be grade 2, in which there is a round head, but it's actually a large mushroom-like head called as coxa magna. This is grade 2. In which grade 3, it's an oval, a mushroom-shaped head, in which the actually head is not round, but either it has an oval shape or it's an oblong shaped head. But it's large head which is not completely round, and it becomes more oblong shape. This is grade 3. In grade 4, the actually head has not completely remodeled, resulting in flattening of the head. And this problem is that head is flattened, but it's only the head which is the problem here. Overall, the acetabulum, the contours of acetabulum are well congruent, and the head is actually lying inside the acetabulum. This actually signifies that, okay, fine, the head is gone, there is flattening of the head, but there is no subluxation or dislocation at this stage. And grade 5 means now the head has become flat and it actually started coming out of the acetabulum with incongruent acetabulum, which means that there is some form of subluxation of the head as well. Therefore, as the stage progresses, there is actually means there increased chances of AVN, and this you need probably some sort of a surgery would be required later on. Usually, Stulberg classification is for the healed Perthes, or called as healed Legg Calve Perthes disease, in which sometimes the deformity of the head has to be corrected so that problems such as impingement and such as limp, which may be treated later on. Usually by this time, if it's already grade 4 or 5, the AVN of the head would have probably occurred by this time. For example, this other staging called as Waldenstrom staging. Now, Waldenstrom staging is actually the more of a pathophysiological staging for LCPD. What it says is that if, for example, at 4 to 5 years of age, there was some traumatic event or a vascular trauma which occurred, this resulted in some form of a problems or disruption of the blood supply of the head of the femur. Now, once the blood supply is cut off, the changes will not start to occur quickly. They will take time and it will progress gradually. The first stage is always, this initial stage is called as the stage of infarction, or it is also called a stage of in which actually ischemia has occurred and the bone has become infarcted or necrosed. Once that happens, from then it comes the next stage. There is increased sclerosis of those kind of bone, in which once the bone has become more necrotic, it becomes more ivory white on the X-ray. There is increased sclerosis, it's more whitish, and then from that stage it actually starts to fragment into pieces. And that stage is called as fragmentation. From infarction you go to fragmentation. Now, once the fragmentation has occurred, by this time it takes around 6 months to reach this fragmentation stage, and after the acute event, after 6 months you can see the fragmentation, and you can think of that something happened 6 months earlier, because acutely usually there are no changes which are seen on the X-ray, and X-ray may be absolutely normal. Even the MRI may be normal. You will only see regions on the bone scan. From then, the bone starts to reossify. This is the third stage of the healing. Once the fragmentation has occurred, now the bone has to heal, and it heals by reossification. That is, the osteoblast starts to proliferate over there. They osteocytes starts to mobilize themselves to the area, eventually turning into osteoblast, and osteoblast lays the new bone. This reossification progress, if you see it over here, You can appreciate this is the increased sclerosis which is happening right over here. Now this is probably the injury has occurred. Later on, if you can see, this is where the central pillar and the medial pillar, which is where the maximum fragmentation is. And now this reossification has started to occur. If you see, this is more of a reossified bone. There is some sclerosis, means this part is relatively more avascular, but eventually it will remodel. And from third stage, which we move to the fourth stage, which is called as remodeling. Usually it takes about 6 months for the fragmentation to appear. From 6 months to 1 year of the time, this reossification starts, and it may progress up to 1.5 years. From 1.5 years or 18 months to almost 2 years, some say up to 3 years, actually this remodeling take place. And by the time 2 to 3 years, this is actually a natural history of Legg Calve Perthes disease. If a child has started having a problem at 4 years of age, it will, if everything goes fine, the head will completely remodel by the time the patient is around 6.5, or maybe 7 years of age. And that is something you need to remember, that this is a natural history, and that is something you need to counsel the parents about as well, that how this disease will progress and how this disease will evolve, and eventually it will be better for the child before embarking on any kind of a surgical intervention. Now imaging, what do we do once we have done with the history? Once we have made our examination, what were the problems which we were thinking of? We were thinking of LCPD. We were thinking of, if there was no history of trauma, then we were thinking of infection only because there was a raised ESR, so slightly raised ESR. We were thinking of, there was only 1 day history, therefore we have to keep acute transient synovitis in our mind as well. And these were 2-3 main differentials which were in our mind. Once we get made our differentials, then we go for X-rays later on, and we have to get with other hematological workup. As on X-ray, the classical sign for LCPD is always the gauge sign. It's also called as the V sign. If you see clearly over here, this is the acetabulum, this is the head, this is almost medial pillar, lateral pillar, this is the lateral pillar. If you can appreciate, there is a V-shaped sign due to fragmentation, necrosis. The bone is actually, there's a dent on the lateral pillar. This V-shaped sign is called as the gauge sign, which is very much evident once the infarction stage is crossed and fragmentation is just about starting. And this is also one of the signs which may presently or may point out towards the diagnosis of LCPD. But you have to get other things as well, like we got our MRI done. Why we were wanted to have an MRI? Because if it would not have been LCPD, it could have been acute transient synovitis of the hip joint. We would have noticed the changes in our viable changes in the head of the femur. There could have been associated synovial hypertrophy as well. Then our other thing which was in our mind was septic arthritis of the hip. That would also have ruled out that if MRI and hematological workup would have been abnormal, then we would have been thinking towards septic arthritis. But as our infection marker was within normal limits, there was no CRP and TLC count was normal. Only ESR was mildly raised, but that can be due to the LCPD as well. We had our MRI was very much normal. There was no changes of transient synovitis of the hip or even the septic arthritis. The head was viable. Then, considering the X-rays as well as the hematological workup, we made the mostly diagnosis of Legg Calve Perthes disease. This is a frog leg lateral view, and why we are getting a frog leg lateral view is to actually look for the slipped capital femoral epiphysis. On a frog leg lateral view, if you can appreciate it over the problem, there is no slip of the physis. The head is not gone posteromedially and the neck actually has gone into an external rotation. If this would have been a scaphy, we would have noticed the changes on the frog leg lateral view. And the differentials we have made is we have to rule out all those differentials by our X-rays as well as our lab workup. Now, if we have made our diagnosis based on our history and examination, then we can move with the treatment of the Legg Calve Perthes disease. As I told you, the first and foremost signs or most important things in the history are the painless limb in a child of 4 to 8 years of age, usually associated with one of the risk factors such as socioeconomic status, or there's a certain antenatal history may be positive of some lower birth weight. If once we have we've taken the history, then we on our differential, we on our examination, we have to rule out our differentials. If there was pain or if there was associated with fever, then probably we are going towards infections such as septic arthritis or transient synovitis of hip joint as well. But if there is no swelling, there is no fever, and there is only painless limb of the child and range of motion, which in our case, our patient in case with John, the pain, there was painful limb, but on examination, the range of motion at the hip and knee joint were absolutely normal. So you understand that probably if there have been a septic arthritis, a transient synovitis of the hip joint due to swelling, pain, and other things, the range of motion may also have been affected at the hip joint. But usually the range of motion these children are normal. But the main complaint of the parents is that this child has been limping for, let's see, in our case it was 1 day, but this could sometimes go for 7 days, 10 days, or even 20 days as well. And usually parents come and say that this child has been just limping, painlessly limping for the last 2 weeks or 3 weeks only. So then if we made the diagnosis by getting x-rays of the pelvis, AP and frog neck lateral view, then we have also got the MRI as well as the blood workup to rule out infections. And we have made our diagnosis with Legg Calve Perthes disease, and it's an acute stage. Remember, it's swollen, the hip may be very much painful, the gait is antalgic sometimes. Therefore, we have to start with the non-operative treatment first. And the treatment non-operatively includes that initially making the child non-weight bearing, because if he or she is going to weight bear, this is actually going to increase the problem at the hip joint, therefore increase the chances of head avascular necrosis. Therefore, first and foremost thing is either make it weight bear, non-weight bearing, or make the child move with the protected weight bearing therapies. That is, you can make it the child non-weight bearing for 2 weeks, and then you can start with the graduated or gradual weight bearing programs. After that, you have to keep that in mind that initially you may have to restrict the activities completely as well. From then, once the 2 weeks has passed, then as you start the gradual weight bearing, you have to start the physiotherapy as well, so that the child does not develop the contraction. Because if this disease would have prolonged for a long time, eventually the muscle spasm and contractions will develop, because the child will develop certain postures in which recumbent postures in which he or she actually feels more comfortable. Therefore, there will be actually loss of internal rotation. There may be increased abduction external rotation at the hip joint. Therefore, you have to prevent these contractures from forming. Therefore, physiotherapy is a must, and which must be started within 2 weeks of time. May require an abduction brace, but it's not always required. Sometimes what happens is that child does comes at a very young age, but actually it's an unstable sort of a situation where you have a catarrhal grade 3 or 4, in which actually there's some form of involving whole of the epiphysis, there is some subluxation as well. Therefore, if that happens, you can use abduction brace so that to prevent actually the head of coming out or subluxating out of the congruent stabulum, so that it does not become incongruous. But along with that, the medication is mainly analgesics. So for first 2 weeks, you make the child non-weight bearing. You give them analgesics to make it more pain-free. Then you can start, after 2 weeks, you can start with gradual return to function. That is initially the passive range of motion, with then shifting to active assisted range of motion, and then gradually active range of motion with first partial weight bearing, then with the complete weight bearing. And once that happens, then you can switch to physiotherapy as well, and then the child is gradually rehabilitated to a normal phase. What is important to understand over here is that usually surgery may not be required in the acute stage. We have to prevent avascular necrosis of the head or malformation of the head. And for that, all this actually the modalities are usually taken. But if the AVN does develops later on, or the problems have actually developed into, then there are different procedures which we can do to actually contain the head into the acetabulum joint. That important is to initially you have to go for the containment. There is one term which is one is called as containment of the head, another term is called the correction of the deformity. Initially there may be not a lot of deformity, may not be much marked, and therefore if a child is around 6 to 8 years of age having A, that is already a very good prognosis, and you can go for these conservative managements. But if you see that probably clinically after re-evaluating, getting re-x-rays, you see the head is actually subluxing out or coming out, then you can go for some form of a containment procedure in form of a surgical operation. But usually early on you have to go for some form of containment procedures. Once the child has, let's say, attained the age of 13 or 14 or 15 year of age, and then you get an x-ray and you see a large mushroom head which is actually maybe congruent or maybe even incongruent of the hip joint. Once the head is out of the acetabulum and it's actually subluxated or dislocated, then you cannot go with these conservative measures later on. You have to go with some form of a surgical procedure to actually correct the deformity. And therefore our aim should be initially the containment of head in the acetabulum socket or in the acetabular cup. Medications could be in form of NSAIDs or even bisphosphonates as well. Now coming to the operative treatment. Now there are two ways of dividing it. That is, if the child presents early, then you have to move toward the containment. For the containment, there is initially associated valgus deformity at the neck of the femurs. For that, we go with proximal varus derotation osteotomy with or without acetabular osteotomy. Depending upon if the child is having some form of acetabular dysplasias as well, then that may require the treatment as well. Therefore, if a child comes to you at this age, let's say 6 or 8 years of age, and triradial cartilage is closed, then we can go for periacetabular Gans osteotomy along with the proximal femoral varus derotation osteotomy as well. If you see, this is the stage. Now, if you appreciate it over here, this is the greater trach. This is the head, which has actually collapsed. This very short neck. This, what has resulted in that as this patient would abduct his or her leg, this would result in this greater trach hitting it on the anterior inferior iliac spine, and this will produce the symptoms of femoroacetabular impingement. For that, you may require some form of a derotation osteotomy, in which so that you can prevent this impingement later on. Now, it can be done at the level of neck, or it can be done at the level of trochanteric, or it could be at the level of subtrochanteric level as well, depending upon usually as there is already associated vascular insult. So usually at the level of neck is prevented. We usually go extracapsular techniques, that is doing it at the level of trochanteric level or subtrochanteric level, and these osteotomies can be done to actually correct the deformity and make containment of the head is actually more possible. Then what about the osteotomy? It could be a valgus subtrochanteric osteotomy as well. But once the child has attained an age of, let's say, 12 or 13 years of age, usually once the head collapses, this leads to varus deformity, or coxa vara at the femoral neck shaft angle actually decreases. Therefore, you may have to go for some form of a valgifying osteotomy, so that to restore the actually head back to its normal anatomic biomechanics. Therefore, a valgifying osteotomy can be done, which can be done at the subtrach level. If you can appreciate, this is the lesser trach. This has been done at the subtrach level, so that we can correct the deformity which has actually been formed, so that the patient can be spared of increased femoroacetabular impingement. Now, operative treatment, as I told you, sometimes only the osteotomy of the femur is enough, because the aim of the treatment is either containment, or the aim of the treatment is either to make sure the head stays in the acetabular socket. But if the problem is also at the acetabulum as well, and it's also still some form of dysplasia, or there is actually increased subluxation of that despite having a femoral osteotomy, then you have to go with some form of a pelvic osteotomy as well. And now, usually if it's before the triradiate is closed, we can go with osteotomy such as Salter as well, Or if the trilaterate is closed, then after 8 to 9 years of age, the child has attained that age, then probably we can go for periacetabular Gans osteotomy. Depending upon this is showing actually how we cut and Salter osteotomy and increase the anterolateral coverage of the child with the LCPD as well. But this usually it happens, usually the Salter osteotomy is more commonly done for developmental dysplasia of the hip, but this form of osteotomy can be done if there is associated undercoverage anterolaterally in the LCPD as well. Now, other treatments which may include is acetabular shelf osteotomy. Now, certain osteotomies are called as shelf osteotomies, or it's called these sort of an osteotomies if the child is suppose age is around 18, 19 or 20 years of age. Now he has progressed beyond an age of any salvage procedure which can be done. So probably the best way is to just make sure that you don't have to go for some form of a reconstructive procedure. You have to go for this sort of a salvage procedure, in which it could be a carry osteotomy or it could be acetabular shelf osteotomy. And why it is called as acetabular shelf, what we do is we take some form of a graft of ileum, we put it over here so that the head actually does not comes out, and this actually results in a shelf which can be seen it over here. You can appreciate this is actually it's acting as a bone block, so the head does not subluxate out, and this is called as the acetabular shelf osteotomy. And what you need to remember is that actually this bone block is lying outside the capsule. Therefore, the capsule acts as a kind of a fibrous bridge between the head as well as the bone. Therefore, once the impingement does occur, this will actually prevent the later on increased necrosis or arthritis which may develop by the patient. Therefore, it can actually prolong. By the time the patient age attains of 25, 30 or maybe 40 years, you can prolong it. And once the patient goes around at 40, and then probably we have options like total hip replacements and all these bipolar hip replacements. Hip replacement is an option, but usually that is delayed, because if we do a hip replacement that early, then we may have to revise it very often, and eventually revising the hip may require multiple times of surgeries, and patient may have to go under 4 or 5 types of surgeries in her lifetime. Therefore, usually we do this sort of acetabular shelf or carry osteotomy so that we can prolong the patient and we can delay the development of arthritis due to which may eventually will develop. And once it does develop, we have to go for some form of a total hip replacement. Now, if there is a failure, now failure could be multiple causes. If its failure is quite early, then we may need some form of a hinge abduction. Now, hinge abduction, the mechanism is actually very similar to the shelf osteotomy. That if you see, this is a per-operative fluoroscopic dye has been actually placed, and if you can see, there is definitely some form of a deformed head. There is some medial dye pool which you can be appreciated. Now this is where it is. Now, if once the abduction will occur, this will impinge it on over here. So if we stop something with in form of a graft over here, then we can prevent the abduction eventually, which may actually result in decreasing the impingement. Therefore, the hinge abduction orthosis can also be used, as well as this procedure actually prevents the child prevents the patient from developing eventually femoroacetabular impingement. Later on, if you see it over here, they have done the osteotomy here, and so as a result, the dye pool can be seen in the whole of the synovial cavity, and therefore there is chelectomy may be required along with it as well, because once the head becomes quite deformed, quite large, may require some form of a chelectomy, that is called as this part has to be removed so that it does not actually impinges it and leads to femoroacetabular impingement. We have covered a hip disease which is usually common in children, that is mostly in the male boys and from 4 to 8 years of age. The most commonly presenting symptoms of Legg Calve Perthes disease is that you usually present with painless hip. There is no associated fever or swelling, and as well the range of motion of the hip and the knee joint is usually normal. When you get the blood work, this is usually there is no signs of infection. When the MRI is also normal, But usually when we get an X-ray, we see some changes such as osteonecrosis of the femoral head due to infarction, which may lead to fragmentation, and there may be signs that if we get those X-rays quite late, there may be associated reossification, remodeling of the femoral head as well. And once we have made the diagnosis, then we have to confirm whether we need to, what type of actually the problem is. Is it a severe problem, or is it has a good prognosis or a bad prognosis? Usually having A and age less than 6 years is a good prognosis, but having B, B, C or C with age more than 8 years usually have a bad prognosis. And if age is between 6 to 8, then probably clinically we have to decide whether what we can do as well or not. If initial treatment is always conservative, bed rest, initially non-weight bearing, then once after 2 weeks you start weight bearing and range of motion exercises as well as the physiotherapy. Once that is done, we can, if we have to go for some form of containment procedure early on, we can go for acetabular osteotomy plus minus proximal femoral varus derotation osteotomy. But once the head has become deformed and patient presents late in the teenage, then the probably option is for a periacerebral Gens osteotomy with valgus derotation osteotomy at the proximal femur. Thank you very much. Keep watching sqadia.com.